that was done on a patient who had a kidney mass here on the right side. They were a dialysis person, and they wanted to take this mass out, so they ended up resecting the whole right kidney. Here's what the left kidney looked like. Okay, so April of 2018, you can see the right kidney is gone, and here's the left kidney. That was read as basically, you know, dysmorphic left kidney with some cysts on it.
How come they don't get IV contrast or MR?
I don't know why this patient got an unenhanced scan, to be honest with you. I'm not sure if I think they might have been a recent transplant perhaps, and maybe they just didn't want to give him IV contrast for some strange reason. Some people do strange things, but I agree, it's a good question. Here's another unenhanced scan, same patient.
Because they don't look simple cysts.
Yeah, and there's like, what is that thing laterally, like that heterogeneous area?
No.
So on this scan right here, someone was smart like RT and said there's some weird like higher density component right here. And then they got really smart and they said, by the way, this is not me. And they said that the color of this is different than this cortex right here. And also the color inside the vein is bright. See how that vein color is bright? Almost like a dense MCA sign you'd see like in the brain.
Mm-hmm.
And so this scan was read as like a T3A renal cell carcinoma with vein invasion on an unenhanced CT. That was like the read on this study here.
Wow.
So then they did a study to confirm, and that's exactly what it is. This whole thing is a tumor, and it was invading the vein right there. I thought that was a pretty good call, so I wanted to show you guys that. And if you go back in time, this is the original study when they had it resected, and you can actually see that the mass was there. It's right here. And I think it's a good example of how corticomedullary phase imaging is misleading a lot of times, where your eye starts to see different color things. Plus, when you have the cysts on top of it, you just blow it off. I think if this was in the nephrographic phase, I think it'd be easier to appreciate this, honestly. But the mass was there then. And if they had known this, they would have done bilateral nephrectomies at the time, because the person was getting teed up for a transplant. So that's an interesting case. And then, let's see, I want to show you this one for some reason. Oh, this is an interesting one also. So, all right. So the person's a bladder cancer patient, and again, they have lots of cysts and random things in the kidneys. And they've had their bladder taken out. This is a post-op. They've got a fluid collection, and they have urinary diversion over here. So the kidney in here basically has a bunch of cysts. There's some stones and stone debris in the calyces. There's some gas inside here. And I'm just going to scroll through it a few times, see if you guys can see anything. I went through this a few times and did not really see anything inside this area here, but you may see something I didn't. And then they come in this study with abdominal pain, and this is now only 4 months later, okay, just 4 months later, and there's a bunch of findings. One is that here's the stomach that's coming down, here's the duodenum, and there's a perforated ulcer. There's the hole right there, and there's an abscess that's bathing the kidney. And now inside the kidney, there's this area here, which is mass-like, and is in the hilum. And you can see that this abscess touches the cortex. Maybe there's a little fluid pocket right here or a collapsed cyst, and it touches this solid thing right here, solid looking thing. I'll go back to the old studies. You can see the same area again. Really, I don't see anything there to correspond to that finding. And this is only 4 months later. So the question was, what is that? Obviously, there's a perforated ulcer and an abscess. Is this some kind of focal nephronia infection, or is this actually a solid mass? And if it is a solid mass, what would it be? It is actually not deforming the contour of the kidney, and it's central and hilar. The person does have a history of bladder cancer. It's pretty weird for a urothelial carcinoma to grow this fast, a 4-month period for a mass this big. It's probably 4 centimeters. But it didn't really look like a focal infection, so we thought this was probably like a high-grade upper tract urothelial carcinoma in a patient who happens to also have a perforated ulcer. And in general, we don't like calling multiple diagnoses on the same patient at the same time because it's usually wrong. So in this case, it went to biopsy. We do ultrasound for almost all of our biopsies. I would say probably 95% of them, including kidney. So here's the area inside the kidney, this echogenic area right here. And this is us putting in some helotine afterwards, just like a little coagulant thing. I think I asked you about that, RT, last time, using a little helotine. So this is us taking our biopsy core. And then when we're all done, we put this little plug in there to fill it up. And it came back as a high-grade upper tract urothelial carcinoma growing in the kidney really, really, really fast in the setting of a perforated ulcer. So I thought this was very uncommon, unusual, so I wanted to show it to you.
So what was the path?
High-grade upper tract urothelial carcinoma.
Were there any notes?
No.
No.
I don't see any anyways.
Yeah,
So I
that's
think
really aggressive.
It had a history of bladder cancer, so we talked in the previous case about a field effect. This is a patient who obviously has a field effect kind of a situation, where their entire urothelium is at risk, and usually we screen them every year or so with a CT urogram to see what they have upper tract disease developing. But this is incredibly unusual. Usually you don't see this growing this fast. Usually it starts off pretty slow, but this is weird. 4 months. 1 centimeter per month.
I have a comment about your don't like to give too many diagnoses to the patient.
Yeah.
So there's this, Occam's razor, you want to give put everything under one diagnosis. There's this other thing called Hickham's dictum. Do you know that? What's
it called?
Hickham's dictum, which is that a patient can have as many diseases as they please. And I looked it up one day to see if this really exists, because I'm the only one that says this Hickham's dictum thing. And especially as patients get older, I feel like they can have plenty of disparate diseases. And turns out he is from, Dr. Hickam was from Grady Hospital, which is our public hospital here in Atlanta. And it makes a lot of sense because a lot of our patients at Grady don't get a lot of preventative care. And so they come in with 10 different cancers, and then they have a lot of different issues that are pretty advanced. So I thought it was interesting and ironic that he was from Grady, and that there really is a dictum.
I think it basically, I'm telling you things you already know, but I think it basically has to do with positive predictive value, prevalence of disease, playing the stats and stuff.
Yeah.
I'm going to try to open another one here. We'll see if this works.
This is unusual, right? Because the rate of upper tract TCC is 4 or 5% in a patient with primary bladder tumor. So it's.
Yeah, this is a very rare presentation.
I wonder if the bladder one was very aggressive too.